Welcome everyone to the CIN webinar, Listening to Connect, Patient-Centered Social Needs Screening Using Empathic Inquiry. I'm really looking forward to our discussion today, and you'll get the chance to hear from the Oregon Primary Care Association around the development and evolution of empathic inquiry, which is a conversational approach to social needs screening. You'll also get a chance to hear from Partnership Health Center, which is a community health center located in Montana that recently implemented empathic inquiry into their work. My name is Marie Hubbard, and I'm the program manager for the California Improvement Network, also known as CIN. CIN is a learning and action network fueled by the energy and innovations of its partners and members. CIN is actually the only quality improvement network in California that brings together both commercial and safety net care delivery systems, health plans, and quality improvement support organizations. CIN offers its partners and members the opportunity to discuss challenges they're facing in their work, get advice from one another, and learn about the new work that they're doing. CIN is a project of the California Healthcare Foundation and managed by Health Force Center at UCSF. If you're interested in our organizations, please go to our website. It's located on the screen. So a few tech tips before we get started. Everybody is on mute except for our presenters. If you have any questions, please use the Q&A or chat box located in the bottom panel of your screen. We encourage you to ask questions throughout the next hour. We really want this to be a discussion and opportunity for you to learn from our presenters. This will be recorded. We'll be sharing the recording with all of you who are on the call with us today, as well as anyone else who has registered. If you're currently experiencing any technical issues, I'm more than happy to help. Just send me a message in the chat and I will assist you. So now I'd like to introduce our presenters. We have Stephanie Castano, who's a transformation manager at the Oregon Primary Care Association. We have Ariel Singer, who's the CHC Transformation Director at the Oregon Primary Care Association. Both Stephanie and Ariel drive the empathic inquiry work at OPCA. We also have Toffer Lenhair, who's the Health Equity Coordinator at Partnership Health Center. He has been driving the implementation work of empathic inquiry at Partnership Health Center. So I will now pass it off to Ariel to start sharing her screen and get us started.
All right, thank you, Marie. Just give me one moment to get my screen sharing going. And into presentation mode. All right, there we go. Okay, so thanks for joining us today. Stephanie and I will be handing things back and forth with each other in this presentation. And I'll get us started by telling you just a little bit about OPCA. So we are the membership association for the 32 federally qualified health centers in Oregon. And you can see some stats on the screen here about the health centers and how many people they serve in our state, and what kind of things that they offer across really our entire state. And we at OPCA provide technical assistance and training as well as policy support for our members. And Stephanie and I are really focused on the technical and training side of our organization's work. Okay, so now let's dig into our content for the day. So of course, we're all really interested in doing social needs screening. This is a growing movement with good reason, because we have all this data that is very clear that it's really social circumstances that contribute to health outcomes far more than what we can do in healthcare settings. So in response to all this really clear population data, 6 or 7 years ago, OPCA got involved along with the partners that you can see on the screen here in the development of Prepare, a screening questionnaire that you're probably familiar with that was designed to be by and with health centers to be implemented in health center settings to screen patients for social needs. And really since the beginning of the effort to develop Prepare, we were hearing, and I think this is part of a the larger national conversation, not exclusive to Prepare, um, a really data focused way of talking about social needs. And it was born out of a response to population level data. It makes sense to be thinking about it that way. But we really felt like, well, yes, it is important to be data driven and data focused if we want to improve population health. At the end of the day, one person's data is another person's difficult life experience. And the population data is composed of a whole bunch of individuals. And we have to be mindful about the fact that this isn't just data, this is the intimate and tender details of people's lives. And we wanted to be sure that we didn't just think about this and talk about it in terms of data and end up approaching social needs screening like just another form that we had to deal with in a busy primary care environment. So it felt really important to us to bring a different perspective into the conversation and to ensure that we wouldn't treat this just as business as usual. So, in developing empathic inquiry, the key questions that we were really trying to answer were how can we help the clinic staff be really great listeners and ultimately, through this process of conducting social needs screening, be successful in engaging patients. And secondarily, we want to make sure that the staff feel confident and well prepared, that they feel they have the training and the skills to be able to do this critical work well and to feel good about how they're doing it. So we're trying to answer the question, what does it take to do social needs screening well? And we're going to go through some of what we came up with in response to that question. And I want to acknowledge that it's not rocket science, but it is countercultural. We really don't think that this is business as usual. And I think it's important to start by remembering that even though we do have really good intentions with everything that we do in healthcare settings, that it's not always that comfortable for patients. So I wanted to start with a moment of empathy, really remembering what it feels like to be a patient, because we think that's essential to taking a patient-centered approach. So of course we know that everyone's coming in with their own particular set of circumstances, history, experience that we don't necessarily know about. And then routinely, we ask people to do things that might make them pretty uncomfortable. We put them in small enclosed spaces. We might do procedures that are physically uncomfortable or intimate. We might ask them to be weighed. We might ask them to take off their clothes. There's all these very routine ways in which we might be doing things that put people ill at ease. And we think that it's important to remember, again, good intentions, but this isn't necessarily a neutral activity. And that we need to stop and really think about how can we do this in a way that promotes engagement rather than producing alienation. This is a recently published commentary that does a really nice job of describing some of the key considerations in terms of how we can engage people, design systems that are about engagement. So a great recommended reading if you want to do some additional exploration beyond what we're going to cover in our webinar today. Okay, so then, we've established not necessarily neutral, need to be thoughtful about how we approach this. So what does that look like? Of course, some of the things that are critical here are relevant across really all kinds of clinical change efforts. And if you've been involved in any kind of clinical change initiative, these dimensions probably look quite familiar to you. One thing that we want to emphasize that is just critically important that I don't think we've been able to adequately address in our work with empathic inquiry, and we're hoping to continue exploring how we can do that, is the question of leadership, engagement, and support. And what is the role of organizational leaders in promoting a patient-centered style of engaging with patients and connecting with people around social needs? But where we're going to really focus our efforts today are in talking about the patient relationship piece and what we can do in terms of staff training, engagement, and ownership of that patient relationship approach. And that's really what empathic inquiry is about. So we believe that, all of those elements of clinical change efforts are important, and really that the North Star of patient-centered care is empathy. And we call this approach empathic inquiry because we wanted to be descriptive of the style that we hope to engage people with. Having a sense of gentle curiosity, being really focused on connection and understanding and the desire to connect. So I'm now going to hand things over to Stephanie, who's going to tell you more about empathic inquiry.
Yes, thanks, Ariel. So Ariel did mention again our approach to this and why we feel such a priority to really share this. And we also did hear from our members in Oregon who again were very bought on to the value and purpose of social needs screening, but again, them mentioning their lack of confidence of doing this well in a patient-centered way. So as Ariel mentioned, we developed this approach to social needs screening that really promoted partnership, affirmation, and patient engagement. And to start our journey in putting an empathic inquiry curriculum together, we went straight to patients and stakeholders in this space to really ask them about their perspective, their thoughts, and we collected that information and distilled it into principles. We also went to the trauma-informed care principles and brought that into the curriculum, as well as the motivational interviewing conversational approach. So really empathic inquiry really emphasizes the affirmation of patient autonomy and strength, transparency and power sharing, the evocation of patient perspectives, and empathic listening. And as part of our curriculum, we have several implementation tools, some that are behavioral guidance to kind of really help those who would be conducting those screenings and adding a patient-centered and strength-based communication approach to that. And you can see the link to our website listed if you wanted to do some digging on your own, but also I'll be covering some of the materials that you'll find there. Next slide, please.
Sorry, having some technical difficulties here. I just want to mention while I'm trying to advance the slide that even though we did develop this out of our participation in Prepare, we do think that empathic inquiry in this approach is screening tool agnostic. So it really doesn't matter which kind of screening tool you're using. These principles are really consistent regardless of what your actual questionnaire consists of.
Yeah, thanks, Ariel. We did focus on social needs screening, but as we've been developing, we feel like it is transferable to other approaches for screening as well. And so you can see here on this slide is our journey with empathic inquiry, and you can see that it has evolved over time, and we feel it's going to continue to evolve over time. But as you can see, we started in 2018 with a pilot in which we had, I think, about 10 Oregon health centers participate in our learning collaborative for over a series, I believe around 8 months or so, that included in-person training, webinars, implementation support, and an extensive evaluation process. And this was our opportunity to really see how the empathic inquiry approach could be conducted and implemented on the ground. And we learned a lot from the folks who conducted or who attempted to implement this in their settings. And from their feedback, we found really clear next steps of how we might be able to redesign our curriculum in a way that not just shared the importance of shifting power from the medical to the patients, but to actually model it in the curriculum that we did. And so you'll see in 2019, we partnered with our local or our Oregon Community Health Worker Association to really consult with them and help us understand how we can weave in popular education, which was extremely helpful. And again, shifting that power from experts to stakeholders. And if you're not familiar with popular education, it is a practice and a philosophy that that's really rooted in social justice, but that really conveys that we're all sort of teachers and learners in this sort of shared space, and that we all have expertise to bring to the table. And it also really elevates, again, the differences of power and structure. So, and it's also very participatory and dynamic. So we're really thankful to have ORCHWA, the Oregon Community Health Worker Association, in our state to partner with us and improve and redesign our program. And an example of what of a popular education method that we embedded into our curriculum was the use of a radio play, which is essentially kind of a script for a radio segment that you would hear. And through that radio play, we were able to really include actual quotes from patients and stakeholders that we interviewed, and really kind of tie it into the story of empathic inquiry, and really be in a nice way to be able to really leverage and elevate the voices of patients that we heard around their thoughts around social needs screening. And so we found that to be pretty impactful and an engaging way to learn. And since 2019, we're kind of living in a different space now in 2020. We were doing a lot of our trainings in person. So we would do full day workshops and travel and visit folks in person to conduct these trainings. So a lot of how we had designed our curriculum was to be physically engaging. And then 2020 has been different for many reasons. And we are living in a much more virtual world. And so we are now translating our curriculum into a virtual format that, again, continues to include popular education and other engaging ways of sharing and learning together. And so as you can see floating in the screen in front of you are some of the materials that we've developed and shared with those that we've trained in empathic inquiry. We have our patient-centered principles, which again is the foundation of this work, and where the voices of patients and stakeholders are documented. We have a pre-screener that folks have been using as a way to introduce social needs screening or other screenings to folks. We have a conversation guide, a conversation checklist for role-playing and for guidance, as well as an Oregon case study that we like to share about a health center who was able to do this well. And so all of that lives on our website, again, if you wanted to take a quick peek of what you can find.
Yeah, so we wanted to point you to what's on our website, but then also let you know that we do have additional tools that are available as part of our training curriculum. We wanted to be sure that even if you didn't participate in a training, you could take these tools and use them. And then there's a lot more that we can offer as part of that training effort.
Great. Thanks, Ariel. And a little bit about our evaluation work. When we brought this, or we started this collaborative in 2018 as a pilot, we did, I mentioned, an extensive evaluation process to, again, better understand how these empathic inquiry principles and implementation tools and behavioral guidance really played out within a clinical setting, and how our participants experienced this approach, and also how the patients experienced this approach. And so to get that, to understand what we were, how it was unfolding, we tracked participant engagement. We tracked, we sent out a pre and post survey for those who were conducting the screenings or attending our events. We had monthly reports from those conducting empathic inquiry to understand how the implementation was going on the ground. And also we handed out patient surveys for those who received the empathic inquiry conversation to get a better sense of what their experience was with this approach. And outside of that pilot, when we are sort of traveling and sharing our empathic inquiry curriculum with others, they've been mostly targeted to federally qualified health centers, but we've also been asking them, around, or participants, about their feedback and how we can improve, because we're very committed to continuing to refine our work and be able to, again, share what we've learned and heard. And in overall, what we've been hearing around implementation efforts on the ground, some very common challenges and successes, you can see them here, but one that is not, I think, a surprise to us, and maybe not as a surprise to you all, but a challenge with conducting not just empathic inquiry, but also social needs screening, is the time and space to have these conversations. We heard from those who were implementing this that in a busy clinical environment, it's hard to really kind of sit down and take 10, 15 minutes to have a very authentic and genuine and empathic conversation with a patient who might have a lot to unload, especially if you don't have a separate space outside of an exam room or the waiting room to have those conversations. So that continued to be a challenge. Another challenge that, again, Ariel mentioned early on in the presentation was kind of engagement from leadership. We heard overall that leadership very much valued the trauma-informed and patient-centered approach. However, there's this gap of how much capacity and resources it takes to really do this well. So again, that was something that we heard. Some successes that we had here, especially in Oregon, was from our health centers who are participating in the Oregon Alternative Payment Methodology, which is a partnership with health centers, the PCA, and our Medicaid agency that really converted the fee-for-service payment into per member per month rates for those clinics. And that alternative payment methodology really allowed some more flexibility for health centers to conduct their workflows in a way that was more patient-centered, and that allowed sort of more of this care team expansion. So that was a really positive response from health centers who had that flexibility. We also heard that the ability to role play and practice with the resources or the tools that we provided was really useful. Ariel and I sometimes laugh a little bit because when we tell folks that they're going to role play, that we hear grunts and groans, but at the very end of it, when they get through it and they push through it, that it's actually one of the highlights of the training, because it allowed for them to have a safe space and have peer feedback around this. So that's also something nice to hear, that role playing does help support confidence. And for those who were really implementing this in their clinics, found that using a quality improvement method certainly really helped implementation of this work. So some general common challenges and successes. What we heard patients say, so with our pilot, participants in that pilot were able to collect feedback from over 132 patients from across Oregon. And as you can see here, those 132 patients, the majority of them really felt a stronger connection and stronger understanding of their clinics. They felt as if that the social needs screening was a good use of their time, and it made sense that why they were being asked that within the medical setting. We also heard the majority say that they know more about their clinic and what they can offer in terms of non-medical needs, as well as if they're not able to find those non-medical needs at the clinic, they know where to find them. And this is something that I think we've heard generally nationally about sort of our assumptions that patients would feel offended or not welcome sort of these questions. We've been hearing quite positively that they're okay with us asking and checking in, as long as it's coming from an authentic and patient-centered way. So the patient-centered principles, really this is the foundation and heart of empathic inquiry. OPCA conducted, again mentioned, some focus groups and interviews with patients, patient advisory councils, community health workers, trauma-informed experts, and clinical and operational leaders in Oregon. And from those interviews, we were able to summarize a set of principles from these folks for us to consider as we're implementing social needs screening. And so when you'll see them, as Ariel mentioned, they're not rocket science, but they're also, again, not business as usual, and they can be deeply countercultural and require commitment to fully embed them into your clinical approach. So these are our 9 principles. I won't spend the time reading all 9. Again, you have them listed here, and you can find a much more deeper description on our website. But something just to note, a couple of major themes that you can see across all of these principles is really the ability or intention to give power back to the patient. As Ariel mentioned, our health systems are really designed for productivity. And so in this case, we have really, again, heard from patients and experts around the value of giving power back to the patient. The other is recognizing and affirming patients' expertise and strengths. Again, in our health system, we typically are asking patients what they don't do well, what they lack. And in this space, we heard that we should also lift up their strengths, and we should value their expertise in their own lives, because who else better knows them than themselves? And lastly, the overall theme is around transparency and collaboration, asking for permission, communicating across teams, partnering with the patient around their social needs, because what we've heard is sometimes they might identify a social need, but that might not be something that is of quite importance at their lives right now. So that collaboration piece is important.
Okay, so thank you for that description of Empathic Inquiry, how it was developed, what it consists of. And as Stephanie mentioned, we've been delivering this curriculum and supporting people to do this work in person. And then 2020 arrived with a surprise for us all, with the coronavirus really taking over our world in a really significant way. And we've had to shift our work to now being on screens and on phones instead of face-to-face. And I think the question we're all asking is, can we still do patient-centered care well remotely? Can we still do social needs screening well remotely? And our conviction is that yes, we can. And I'm just going to briefly share a little bit of information about both why we think we still can do it well, and also some recommendations for adaptation to doing this over the phone before we hand things over to Taffer to tell you more about their experience at Partnership with Implementation. So on a personal level, some of my conviction is rooted in my own experience of having been a health coach, using motivational interviewing at a worksite wellness program that was developed at the Oregon Health and Science University, where we did all of our work over the phone. So I conducted thousands of outreach calls and provided health coaching to nearly 1,000 people entirely over the phone. And what I found was that you can absolutely connect well with people over the phone. You can have really effective engagement. You can really convey listening, and you can really accomplish a lot in terms of intimate, deep conversations about health in that format. So the other thing that I want to share, in addition to my own personal experience, is a research study that has some findings that I think are relevant to this question. So this is a research study that was conducted at the Yale University School of Management. And if you're interested in reading all the details, there's a very detailed description of their experimental design and process and outcomes if you click on the link at the bottom of the slide. But I think the upshot is that they did these 5 different experiments where they were comparing different modes of communication, including voice only, voice and visual, as well as multi-sense communication. And what they found was that voice only communication was actually the best performer for empathic accuracy. And their definition for empathic accuracy here was in terms of understanding the emotional content of the conversation. And their hypothesis as to why that might be is that, first of all, we're good at masking our emotions and our facial expressions. We're used to doing that. That's just part of how we're socialized. So that's on the part of the speaker. Then on the part of the listener, we're not very good at cognitive multitasking. So if we're attending to different kinds of cues, not just what we're hearing, but also what we're seeing, then it actually might reduce our effectiveness at really gathering the meaning from each of those modes of communication. Then we also, without training, are naturally listening to nonverbal cues relating to meaning that come through in the voice, including pitch, cadence, speed, and volume. And really, the upshot of that is that meaning is conveyed not just through what people are saying, but how they're saying it. And again, this was the people who were listening in this study were not trained. It was just the natural process of communication. So I think, again, we can conclude that there's a lot of opportunity for voice-only communication to be effective for empathic understanding. And I do want to acknowledge that this study did not specifically look at any dimensions of cross-cultural communication. And of course, that is relevant in healthcare settings, particularly in safety net settings. So something to consider, that there may be some additional challenges with cross-cultural communication, and some additional strategies that are needed to think about how to do that well. So some specific recommendations for doing remote outreach and engagement. So first of all, I think that we can really convey a lot in our voice by just being authentic. So getting into a real listening mode within ourselves before placing the phone call, so that we're really there to show up as a listener and to know that that will come through. Secondarily, I think that we can celebrate the fact that when you're on the phone, you can really lean on a script. And scripts are excellent tools. They're much harder to use face to face. And especially at the beginning, if you have a good script that you're really using and relying on, eventually you won't need your script anymore. It'll be second nature and you'll have developed really good patient-centered communication habits. But I think that's a great starting point and a great opportunity, because when we're face-to-face, I think we can kind of just rely on our normal ways of connecting with people and not necessarily commit to really being consistent with asking permission every single time, and going through all of the processes that we recommend with respect to the patient-centered approach. And by using the script, we can really build consistency and build good habits. We can also convey a lot through our voice that is happening in our physical presentation. Even though the person can't see it, they can hear it. So you can both hear and convey smiling or seriousness. You can use your hands the way you would in a normal conversation, and all of that will really come through. And again, I'm very confident about this from my own experience doing all of that work over the phone. I could always hear if somebody was smiling. You can really hear the emotional tone, the excitement or lack thereof in their voice. I also think it's really important to remember how much we can convey with not talking, and either using nonverbal kind of encouragers or vocalizations, but also by being quiet and taking a pause, taking a deep breath, actually conveys a lot in terms of presence and that sense of like, I am here with you and I am accompanying your experience and taking a moment to just be with you before jumping in. It's like I think conveys some difference in listening to understand versus listening to respond. And one thing that I want to also offer in closing here is something that was shared with us by a person who leads a community health worker program here in Oregon, that she really emphasizes with her team, that it's true that we're not always going to be able to offer patients the resources that they need. There isn't enough affordable housing to go around, and there are real challenges in our communities, I think now more than ever, with the impacts of COVID on making sure that people have the resources that they need. But at the end of the day, even if we cannot offer them the resources, we can always offer them support, respect, and kindness, and be there as a compassionate and strengths-based listener and supporter. And that if we really bring the authentic desire to show up in that way, then that has intrinsic value and will really have an impact. So I'll close with sharing this conceptual framework that's really a kind of guidance concept for us and how we think about transformation at OPCA, that this is really all about listening. That if we can do a better job of listening to our data and then taking what we know from a population level and connecting with patients and really listening to them and centering their experience and lifting up their experience, and then we work to change care and to connect with them and support them in new ways, and then continue to listen to see how is that going and what can we do to continue improving it, that we can just keep working, iterating, improving our way to a transformed healthcare system that's not just improved in technical ways, but also in relational ways and feels more human, more focused on patient priorities, agency, and empowerment. So I'll leave this slide up for just a moment so you can jot down our emails if you're interested in reaching out to us with a question or two. We're always happy to hear from you. And I am going to stop sharing my screen and get ready to hand things over to Taffer.
Thank you so much, Ariel and Stephanie. So as Taffer is trying to get his, or sharing his screen, I just want to acknowledge, in the interest of time, I think we'll just move into Taffer's presentation so that you can hear a little bit about the implementation at Partnership Health Center. But I will say that I see your questions in the Q&A box and encourage others to ask questions, and we'll get to those at the end of the hour as we can. So thank you for those who put questions in. Please keep them coming, and I'll hand it over to you, Taffer.
Yeah, thanks, Marie and Ariel and Stephanie. That's always inspiring, and I think just all the layers there that has informed our work at Partnership. Just really appreciative of that framework that you've kind of given us to work with, and so. Yeah, I'll be talking about a recent, just this past spring, kind of late spring, early summer, of some outreach that Partnership Health Center did using exactly what we've just been talking about. And so, yeah. Just as an overview here, I'll tell you a little bit about Partnership, and then how we did some of that, engaging their leadership and getting our clinic buy-in, and then how we actually implemented this, what it looked like for us to talk to patients. So, Partnership Health Center, PHC, is a federally qualified health center in Missoula, Montana. We've been around since 1992. Started off in our city county health department, and now we're a full clinic with primary medical, with integrated behavioral health. We have a pharmacy and dental. So for people in Missoula, we are a one-stop shop for them to come to, and we take that very seriously, that people really entrust us with their healthcare. And so we are having conversations internally about how we can respond to our patients' needs. Becca Go, our Director of Innovations, was crucial to really bringing this to the rest of the clinic and integrating it in. Alana McCreary was really helpful in kind of piloting some early versions of this before we did it by telephone. Alana supervised our community health workers in a pilot that I'll describe in a moment. And so it was really a collaborative effort. We really take the team approach very seriously at Partnership, and so have to give them some recognition and a little shout out here today. So furthermore, I mean, I think that piece that Ariel was touching on about leadership is really important. Lori Francis, who Partnership soul from the Oregon Primary Care Association. She left them to become our executive director, and so her valuing, her willingness to prioritize the social determinants of health, and also just a more empathic, you know, opportunity for our staff to engage our patients in an empathic way. So having that leadership at the top, can't stress how important that is to have that priority. But then our clinic operations, our behavioral health team, and our quality improvement department were all really integral in getting this outreach going. They all had kind of different levels of buy-in. Of course, maybe where you are, different departments have their own priorities and what they want to see. And so we really tried to be flexible to those different needs. And so for us, you know, reaching out to certain patients was kind of up in the air of who we most wanted to hear from immediately. And so clinic operations told us that some patients that maybe hadn't been in for a while was important. And so, yeah, we were just able to prioritize different things. And once again, the data collection here, I think, was really important, that we wanted to make sure as we were doing this outreach that we were gathering information that we could use later, while also providing a really like engaged, attentive patient experience. And so trying to do those two things well. So those were our priorities. And then of course, it's really important to get clinic buy-in. Some of this social needs screening is relatively new still at Partnership. And so making sure that staff understood what we were doing, why we were asking some of these questions, and also letting them know that it wouldn't be additional work for them. That that's always good news when you can go to a department meeting and tell people that they have no more work added to their plate, but instead we get to bring maybe some data and perspective to them and help them understand the patients that they're interacting with on a daily basis. And once again, we're able to do that because my work was centered around this, my time, and also Alana's time. So once again, we had dedicated staff that was able to help us roll this out. And which is important as we talk about, you know, this empathic inquiry, being present, you know, all those things that Ariel was reminding us of that, you know, just taking that pause to take a deep breath. It's actually kind of, you know, easier to do that when you're like at home like this, and you're not in a busy clinic with maybe lots of other noises going on, but we were able to be focused and there for our patients during this outreach. And we used a app called Doximity, which is really great. It masks, because we were using personal cell phones, because we were working from home, it masks my phone number, so my cell phone number isn't shared with the patient. But then also it protects patient privacy because it does not store the patient's phone number on my phone. And so if you're concerned about patient privacy and HIPAA, doing outreach through that smartphone app, it was just something that Partnership had bought into, was helpful in doing this outreach since we weren't on our secure landlines at the clinic. And then the other thing that we were sensitive to is we were expecting to see maybe heightened rates of depression or anxiety, that patients would say they're experiencing those symptoms at a higher rate now. And so we wanted to be able to offer integrated behavioral health. Behavioral health is integrated into our primary care, and so we wanted to be able to extend that to this outreach, and let people know that we had staff available for immediate handoffs. And that was all part of our step-by-step instructions and a script that we thought about how we would integrate that. And that was also taking advantage, once again, integrated behavioral health is very important to our clinic. We have staff dedicated to that so that any patient, while they're in our clinic or even now in telehealth, can get access to a behavioral health specialist. So that was still wanted to prioritize that. And then once again, this work that I'm talking about today was definitely inspired by work that we were doing with our community health workers. And so we already had that program up and running. There was 3 community health workers that were engaging patients. And through their interactions, as we were describing, that script can be very important. And when you have people, staff that are not used to maybe engaging with patients over some of these more sensitive topics, having a script to help guide them at first can be, we found very, very helpful. And there's also is just that constant reminder whenever you go back in that this is like a practice. So it's a way of kind of thinking and being. And so when you have that script to rely on, it really helps you internalize that. But then we also had just other more kind of bureaucratic workflows. The process that we use at Partnership Health Center, eClinicalWorks is our electronic medical records. We already had some space created in our calendar for the community health workers, and so we were able to utilize that scheduling so that all of the encounters that we had were documented in the patient chart so that their medical team could see it. And that's just once again another value as we're trying to integrate medical, behavioral, and these social needs into the patient record so that when their primary care doctor sees them the next time, they have this information available to review. The script cannot say how important a script is. Once again, for us internally, it helped us all get on the same page. There's things that Ariel and Stephanie were describing, just so that we were all sharing the same language and approaching this in the same way. So that script is great, but as great as a script can be, you know, there was also not pressure to use it verbatim, that we each have a different style of talking. We all have different life experiences that we're comfortable drawing on. Self-disclosure is really a valuable thing in this that I'll get to in a little bit, and being able to tell your own story and bring your own experience to connect with that patient is important. So being able to have a script that can help be your guide, but also not be a you know, not limiting and letting you bring yourself to the phone call. One of the things that we really tried to emphasize in our phone calls was this strength-based conversation, and so kind of focusing on the courage of this moment of talking about these things. Once again, that somebody would take 15 minutes to engage their health clinic in a conversation about the social needs, and revealing that, especially in the fallout from COVID, that people are experiencing more symptoms of depression, anxiety, but also that you paying your bills and that feeling that you know, you might have been the provider and now you're not anymore. And that takes a lot of courage to admit that to a health clinic, that the situation has changed. And so we really wanted to honor that and give people multiple opportunities to opt out of the conversation. Since we do touch on so many sensitive topics, we wanted to let our patients know that at any time they can opt out. We reminded them often in conversations, patients would laugh. On the third or fourth time, I offered the opportunity for them to not continue because they felt like, no, I'm okay. I said I would talk to you. But I think that that's the type of relationship we want to establish with our patients, that we can even laugh about these things, that we can kind of be vulnerable and be like, no, I'm cool. It's fine. Keep going. That type of rapport, I think, is what we want to establish. And that rapport allows us to get to some of those heavier topics that we want to get to in social needs screening, and also the honesty that we want people to bring to the response. We don't want them to gloss over anything. We want them to feel like they can truly tell us what's going on in their life. And one of the things that I can be, like, just my personal style is not, I've really grown to loathe surveys. Recently, I feel like that a survey style interview is great, but also I feel like we take a lot of agency away from patients when we ask survey questions, because sometimes they don't always know how that survey question is going to be used. To me, surveys are often like a snapshot in time that you're not really sure the context around it. And being able to ask these open-ended questions and framing it also, you'll see here in this question, we've heard from many of our patients, framing their response in a collective sense so that it's not maybe an individual who is struggling with job loss or not being able to pay bills or their housing being unstable, that those are, right, when we talk about social needs, those are a collective problem, a collective concern in our community. And so helping kind of just frame things that way, and then asking that type of open-ended question, you know, what's concerning you right now, allows patients to take this in a lot of different directions, right? And some patients are more medically focused and they want to talk to you about their medical issue, but also in this moment, patients have brought up COVID-19 and just how they're kind of feeling, what they're seeing about it. And then of course they've brought up Black Lives Matter and some of the other issues that are happening in the media and that are affecting our country. And for me, that's really worthwhile, because that type of, we want people, I think, to bring their whole selves into the clinic, to share what they're experiencing. And so when they can bring all the things that are on their mind to a conversation like this, I think it really helps us understand as a clinic what they're experiencing and what they might need from us. And we know definitely in Missoula, Montana, active listening feels more and more important, because this listening to understand and not respond, in Missoula, we do not have the resources to, as I'm sure California and Oregon, you know, we don't have an unlimited social safety net to provide for everyone's needs. And so knowing at the front end that we could talk to patients and know that that we're not going to be able to access all available resources. I mean, maybe we can help you a little bit, but that we're really here to listen to you, to support you, to figure out what you value and how as a clinic we can work alongside you to reach those goals, rather than just responding, because we know those resources are not going to be adequate always to meet a patient's needs. And I think as a health clinic staff, that also just takes a little bit of like the weight off of our shoulders to know that we are not going to be able to solve everybody's problem, and to acknowledge that to ourselves, to acknowledge that to the patient, I think kind of helps us just work on a level footing there, where we know that things are kind of, we're up against some really big, tall problems, and that we need to work together to solve them. And that humility too comes in here. I just think about a patient that was talking to me about not being able to pay their utility bills, really struggling, feeling like their housing was secure, but some of their bills might not be, but then going back to school right now and needing to pay for some technology. And our community people have been talking about, oh yeah, we should provide families with some technology. And this patient said like, they just were really not interested in a new laptop when they couldn't even pay their water bill. And that type of like cognitive dissonance in our patients, what they experience and what as a health clinic we might try to help them solve for, you know, we were thinking, oh, we can help them solve for technology, when they were thinking bigger picture, and they were telling us what they needed was like, they just want some of their basic needs met. And so that really helped us reframe what we were prioritizing and what we were thinking about as a clinic. And then once again, just wanted to frame kind of this in the larger area, that these are social needs are, you know, the social determinants of health as well. And so as we think about, you know, employment with a comfortable income, stable, affordable housing, a supportive social network, those are things that are on our patients' minds. And then the kind of the next step out of those structural pieces here of systemic racism and systemic poverty that really impacts our patients, that as Ariel was describing, our patients, they see all of this, right? They understand that this is how the social needs impact their health and well-being, and that the option of going to you know, a fast food restaurant compared to cooking a meal might not be possible, because they might not have the money to go buy food at the grocery store at that moment. They might not have the time because they're working longer hours. They're traveling to get to their multiple jobs, right? So how all this stuff plays in, our patients are aware of it. And I think they were really happy to hear us engage on those issues, that we weren't kind of shutting that off. And as far feel like I'm running a little bit tight on time here, so I'm going to try to wrap up with some of our telehealth implications, which I think before we were meeting patients in the lobby to have these conversations. And in the lobby, there's some privacy concerns. The lobby is kind of a public space that people are coming in and out of. And if you can think about your own experience waiting in a lobby for maybe you're going to get blood drawn for some reason, or you're just having some type of pain that you want to get checked out, right? So your attention is not really drawn to thinking about these social needs. And so when we thought about what telehealth would do, we thought it would help us have really intentional conversations, that we could really think about what type of target population we wanted to do outreach to, who did we need to hear from, rather than just the 16,000 people that come into our clinic each year. That's a lot of people. Like, we got to figure out how to prioritize who we want to listen to in some way. And telehealth actually kind of presents us with that opportunity, because people are not coming as frequently into our door. So that kind of lets us think about that in a new way that I think is really exciting. Disconnected phone numbers are definitely a thing. If we're getting down to kind of some of the nitty gritty. But one of the things that can be from is when people are living in poverty, that phone bill might be something that they choose to cut one month and then they bring it back on the next month. And so we found that we would call numbers again, even though they said they were disconnected, and it would be reconnected to that same patient. So don't let disconnected numbers discourage you. And then the other thing that we experienced that is kind of maybe a hiccup in telehealth right now is displacement from COVID. Called a few people that were living in different parts of the state or had left the state looking for work or to be closer to family. And so that's just another reality right now, that if they're coming into a clinic or coming into a space, obviously they're right there, they're around. But doing telehealth kind of presents some interesting dynamics there. And I think the main thing that, just to emphasize this, that I think Ariel's and Stephanie's data backs up, and something that we experienced was that patients thought this was completely relevant, that we would be asking about these things, and they were grateful we called. Even people that declined to participate in the full prepare screener still told us that they thought it was really great that, like, the health clinic was calling them and that we wanted to listen to them about these experiences. And so once again, that just felt kind of validating and affirming to hear that patients were finding that conversation worthwhile. And that's my contact information. And I think we have a few minutes now, hopefully not much time to get to some questions.
Yeah, thank you so much, Toffer, and thank you again, Ariel and Stephanie, for this wonderful content. I will ask one question that's been here in the Q&A, just around retention of staff. So, Ariel and Stephanie, what have you heard from your members and other partners that you've done this training with? How has Empathic Inquiry, retained staff at clinics? And for you, Toffer, with your colleagues, what have you seen at partnership?
That's not something that we've been able to evaluate. There's a lot more evaluation that we would love to do that we just don't have the resources for. So I don't have a data-based answer to that question.
Yeah, I think for us, the sample size is very small. There was a couple of us working on this project, but I know that, speaking from my own experience, it was very framing this information in this way, doing this type of outreach, was very, I think, very purposeful, and it felt good to be part of, the social needs part, really contributing to the medical team. So that was, from my own experience, that was like a bonus here, and I think something that we're excited to continue, and I think that it will help make people feel more productive, or more have more self-efficacy at work.
This is Stephanie. I'll just add, I took a quick peek at our evaluation that we had for our 2018 collaborative, but something that, we did look at job engagement, and really there was not much difference between our pre and post, maybe a couple percentage up. But I just wanted to also share anecdotally too, we heard from a nurse who participated in our empathic inquiry training as our pilot, and said that she's been a nurse in that community for years and years and years, and she's been seeing the same patients for years and years and years. But that with the empathic inquiry approach, she was able to really learn more deeply about them and establish a much more deep relationship with them that she hadn't otherwise after years of practice within that clinic. And so that she really took that approach in a way of being able to connect more deeply with patients. So in her experience, she felt that she was making much more of an impact, or really getting to know her folks this way.
That's great. Thank you so much. And thank you, all of you, for this wonderful content and for taking the time today to share your knowledge with CIN. And thank you, participants, for joining us. I'm just going to launch a poll now to get some understanding of how today's webinar went, so we can continue to modify our programming to best meet your needs. Again, thank you, Stephanie, Ariel, and Toffer. We really appreciated having you today, and we hope everyone enjoys the rest of their day.
Thanks for having us.